I am honored to introduce today's Grand Round speaker, Dr. Damani Piggott. He is currently an assistant professor in the Division of Infectious Disease at Johns Hopkins School of Medicine. He obtained his undergraduate degree at Morehouse College in Atlanta, Georgia. He then went on to receive his master's in science and philosophy degrees, as well as his PhD in immunobiology at Yale University Graduate School. He also completed his medical school training and a residency program in internal medicine and pediatrics at Yale. He then completed fellowships in infectious disease and epidemiology at Johns Hopkins Schools of Medicine and Public Health. As an infectious disease clinician and immunologist with expertise in epidemiology and quantitative research methods, his research focuses on understanding the biological and behavioral mechanisms needed to promote healthy aging in persons living with or at high risk of HIV. With K23 support through the National Institute of Allergy and Infectious Diseases, he has studied and characterized frailty among HIV-infected persons with a history of injection drug use and the role of inflammatory pathways in that process. He has worked as a clinician in the United States, Caribbean, and Sub-Saharan Africa, which has directed his research to improve clinical outcomes for marginalized HIV-infected populations. We are privileged to have him here as our guest, so please join me in welcoming Dr. Damani Piggott.
Thank you, Alyssa. And thanks so much to the entire WAKE community, to Dr. Rosenthal and Dr. Sanders, Dr. High, Dr. Schaefer, Ruth and Susan, and everyone else for the just warm hospitality and welcome. It's great to be back in the South. And it's going to be my pleasure to talk a little bit about the work that we've been doing around frailty in the context of thinking about the HIV-infected population as it gets older and thinking about vulnerability and disparity. I don't have any disclosures. So we're going to talk a little bit about some of the epidemiology of frailty in this context, talk somewhat on putative biological pathways at the intersection of HIV and frailty, focus on inflammation, and then again talk a little bit about frailty itself as a key potential target, thinking about the disparities that exist in HIV as folks get older. So as you know, the HIV epidemic, which has existed now for over 3 decades, has had substantial impact on the world. 35 million people have died of HIV since the initial onset of this epidemic, and there are an estimated 37 million people living with HIV worldwide today. We've had some significant success initially with the development of great medications for HIV, and as science is, we always want to get what we do with science into practice, and so the actual implementation and rollout of and access of antiretroviral therapy around the world has been key. And over the last decade and a half, that has really increased substantially from about just under 700,000 folks in 2000 to 15 million people by mid-2015 having access to effective HIV medications. A lot of that in part due to efforts led here in the US as well. So as a consequence of that, folks with HIV are living longer, and the number of older HIV-infected adults around the world is substantially increasing. So it's estimated that there are about 4 million adults. And I know for the geriatricians in the room, 50 seems, and for others in the room, 50 may seem on the younger side, but that's the number, magic number that folks have been using HIV as older. And so there are estimated 4 million folks, HIV-infected persons 50 years and older now, and it's anticipated this number actually may triple in the next 2 decades or so. This has been happening here in the US for some time, so there's been really increased survival. As with increased survival, there's been a rise in the number of people actually living with HIV as well, and there's a shift in the aging structure of the HIV-infected population. So it's estimated now that about 45% of US persons living with HIV are now 50 years and older. And so, despite these tremendous survival gains, there are still gaps that remain in mortality for HIV-infected versus HIV-uninfected adults. This here is data from the Kaiser Permanente California cohort. This is a cohort that otherwise has good care, and it's looking at mortality rates over time for the HIV-infected and HIV-uninfected adults. So you see here in blue, the HIV uninfected individuals, and mortality rates have slightly declined maybe, but about the same. As we know, so for HIV infected adults in this cohort, there was a significant drop in mortality rates with the advent of antiretroviral therapy, which continued. But still here at the last evaluation in this cohort, there was still this 13-year gap that existed between the HIV-infected and HIV-uninfected population. And these survival disparities, even within the HIV-infected population, there are disparities that exist in the survival, and it's most severe for HIV-infected racial and ethnic minorities and persons with injection drug use, among others. This is data here from the NA Accord, which is a collaboration of HIV cohorts throughout the US and Canada. And it's looking actually at life expectancy from age 20 for HIV-infected participants. Actually, this is actually for folks actually on ART. And you see here that you've had some approval in the life expectancy gap that exists between folks, whites and non-whites in this cohorts with time, though still some disparity exists. And then here you can see that persons with injection drug use, marked by this green line here, IDU, they have the most significant disparity in terms of lower life expectancy. So the question is, why is this? And so one issue is that we still have gaps in coverage to achieve and maintain virologic suppression, which is in the absence of a cure is what our primary goal has been clinically. And so this is the HIV care continuum that a lot of you probably are very familiar with. Effectively, of the 1 million or so folks living with HIV in the US, 86% or so, as of the CDC's recent numbers, actually know that they have HIV. 64% are actually receiving receive care, and then about half or so, 50%, retained in care and virally suppressed, again, which is our goal. But that also means that 50% are not virally suppressed, which appreciably comes with increased mortality and morbidity risk itself. So that's one thing that definitely we still have a struggle with. But the other key thing that is the topic for today is this rising burden of aging-related disease and aging-related syndromes that we've been seeing as folks are living longer now with HIV. And I'm going to particularly focus here on frailty. So I know we're in a mecca of geriatrics, so I know a lot of folks probably are very familiar with frailty, but I will talk a little bit about it here. So frailty is a critical syndrome of vulnerability to adverse health outcomes. So that includes mortality, hospitalization, disability. It was first characterized among older HIV uninfected adults, 65 years and older. And it's been conceptually considered to reflect a decreased resilience or ability to bounce back after one is hit with either an internal or external stressor. From a biological lens, it's been considered to potentially reflect a cumulative decline in multi-system physiologic reserve. And the key point here is that frailty, while aging related, is not equivalent to chronologic age, again reflecting the heterogeneity of the aging process. So I think we all have in our minds a picture of what a frail individual may look like. I draw one example here. This is former President of South Africa, Nelson Mandela. And you can see over here, this is in his younger to middle age state, and he's pretty robust. He's getting a little bit older here, a little thinner. And then this is last picture here is him relying on his wife, Graca Michelle, to move around. He's lost a lot more muscle mass. He's very gaunt, and this actually is not too long before he passed away. So this has been codified more specifically in the literature over the years, and amongst the earliest conceptual models of frailty was that detailed by Buchner and Wagner back in 1992. And they defined a course, so this is the non-frail individual here. This is physiologic capacity on the y-axis, time on the x-axis. And at this point, this is what they propose in terms of folks who potentially were frail, so they take a different trajectory, right? So a more accelerated decline in physiologic capacity. At this point here, if you get hit with some sort of stressor, again, like the flu, right, or in our times, coronavirus, that you have, how you respond to that depends on what your physiologic reserve and capacity is, or your frailty status. And so how sick you get, right? If a frail individual is more likely to be hospitalized than someone who's non-frail and staying home. And so there's that concept of how acutely ill you get, and then your ability to bounce back, right, or not. So that's been sort of the earliest conceptual models of frailty. This has been operationalized over the years in several different ways. This is one of the most common ways in which frailty has been operationalized, and this is a physical frailty phenotype, which was described by Linda Fried and colleagues in 2001 as this altered the cycle of negative energetics and muscle mass and quality, sarcopenia, reflected in terms of presentation across these 5 domains: weight loss, weakness, exhaustion, slow gait speed, and low physical activity. And in this construct, a person who meets a critical mass of 3 or more of these criteria is classified as frail. And then there was these other categories: pre-frail, 1 to 2 criteria, and robust, 0. Now, frailty and HIV actually share significant disparities as well. So they share geographic disparity and other disparities as well. So this data here actually is from the National Health and Aging Trend Study, published by Karen Bandy and Roche and colleagues. And this speaks a bit to this. Overall, the burden of frailty, this is US adults 65 years and older. This is not a HIV-specific entity. But the overall burden of frailty in the NHATs was 15%. But as this broke down, you can see some notable findings in terms of discordance between groups. And so just looking at the region in red, Kentucky, Mississippi, Alabama, Tennessee here, you can see that for whites in the highest income quartile, the frailty burden was 5.6%. For blacks in the highest income quartile, this burden increased to 8.3%. For whites in the lowest income quartile, this burden increased to 29.6%. And for blacks in the lowest income quartile, the frailty burden in this national study was found to be 39%. So again, notable disparities in frailty burden around the country. HIV, similarly, in terms of, in addition to the geographic disparities that are observed, we know that certain groups are still disproportionately burdened by HIV. So for US blacks, we represent 13% of the US population. 43% of new HIV infections actually occur in this population, and 42% of persons living with HIV also as well. We know that there's a higher burden of HIV with folks who come from backgrounds with socioeconomic challenge, including by income, education, and employment. And then we know that persons with a history of injection drug use, as I mentioned, also disproportionately burdened. So 17% of persons living with HIV U.S. persons with injection drug use represent 70% persons living with HIV. In the most recent data from UNAIDS, persons with injection drug use are actually the one group where globally the actual incidence of HIV is actually growing up. And that's reflected in this graph here as well. And whereas the percentage of HIV-infected persons in the global population is probably about 0.005%, 12 to 18% of globally of persons with a history of injection drug use are estimated to be living with HIV. So with these disparities in mind, thinking about how do we close the gaps and target the vulnerability of these populations, we've been doing work in a cohort called ALIVE, the AIDS linked to the intravenous experience cohort. It's a Baltimore community-based prospective observational cohort, and it was set up at the beginning, towards the beginning of the HIV epidemic back in 1980s, to look at the natural history of HIV infection in parallel to several other cohorts such as the MAX and the WISE and so forth as well. So ALIVE consists of HIV infected and HIV uninfected adults. So it allows with prior or current history of injection drug use, and it allows teasing out of HIV-specific effects. It's a predominantly African-American cohort, 90% of the cohort is African-American, and there's high socioeconomic disadvantage. So 60% of our cohort has not completed high school, and 60% have an annual income of less than $2,500. Frailty assessments were actually incorporated into ALIVE in 2005, at which time the median age of our cohort was about 48 years. And so the first thing that we observed was that HIV infected participants in our cohort were 66% more likely to be frail than their HIV uninfected counterparts. And this is controlling for other factors such as age and other socioeconomic factors and so forth that are associated with frailty in our cohort. And so definitely in our cohort as well as in several others additionally, overall there's been found to be this heightened frailty burden with HIV infection. And so the question is, in a sense, what does that actually mean? And so what I mean by that is I talked a little bit about the fact that we talk about what the cutoffs are in HIV in terms of age, but a lot of the frailty work preceding this had been done in population over 60, over 65. And so I think initially when we began this work, there was several questions about, well, is frailty actually relevant to younger populations? This is a construct that's been developed in a different population structure, and does it matter really about frailty in HIV and in these younger populations, and clearly for PWID as well. So we looked at what does the frailty measure actually mean in terms of outcomes, and we first looked at hospitalization. And so we found that frailty actually is a significant predictor for hospitalization risk in our cohort. And this is actually independent of how advanced your HIV disease stage is or how much comorbidity you have, and these other factors as well. We found that this was most pronounced actually in terms of prediction of chronic disease hospitalizations, as well as infectious disease-related hospitalizations as well. So then we looked at the relationship of frailty to mortality. And for this, again, this is in ALIVE, and looking now here just to orient you, if I can see my colors, the blue line here is for folks who are HIV negative and not frail. The green line represents folks who are HIV negative and frail. The red line here represents folks who are HIV positive and not frail. And this bottom line here, the deep yellow, represents folks who are both HIV positive and frail. And so if you're either HIV infected or frail, you're about 3 times more likely to die in our group. But if you're both HIV infected and frail, is 7 times more likely to die than folks who are not frail and not HIV infected as well. So significant consequences for our population in terms of the impact of frailty as well. So there have been multiple studies done in HIV cohorts that have both confirmed what we have found, as well as have found other associations of frailty with key geriatric outcomes. So this includes mortality, hospitalizations, onset of falls, fractures, incident comorbid chronic disease, disability, and decreased quality of life. So pretty much all the things that have been considered to be significant outcomes for frailty in the non-HIV population have been observed now as well in HIV cohorts. So appreciating the significant impact that frailty has on outcomes such as these, both hospitalization, mortality, and beyond, the question is, how do we reduce the disparities that exist in HIV outcomes by targeting frailty per se? And to do that, we need to understand what are actually the pathways to frailty in these populations. What are the triggers and so forth? And so that's the next thing that we sought to elucidate. And to do that, the first thing I think to appreciate is that frailty has been considered a dynamic state. And what I mean by that is that, so studies by Tom Gill and others, the consideration is that one can move in and out of frailty states. So it's not necessarily an absorbent state, for example, as death would be. And so that's important in terms of thinking about progression and recovery opportunities for recovery as well. And so we sought to think about these transitions and try to characterize them in terms of what are the potential determinants of these transitions, initially from an epidemiologic lens, and then I'll talk a little bit about the biology as well. So to do that, we looked at just over 1,300 participants in our cohort with 9,500 frailty transitions from 2005 through 2014. And we use Markov transition models to actually make assessments of these transitions. So there's actually a lot of movement. So just to orient you, I'm going to define transitions in a couple of ways and talk about frailty both as a three-tier categorical measure. So again, frail if you have 3 or more criteria, pre-frail with 1 to 2, and robust to 0. And then just talking about frailty as a binary measure, non-frail, 0 to 2 versus frail. So of the non-frail, of all non-frail transitions, 8% of non-frail transitions were to a frail state. Conversely, of all the frail transitions, 68% were actually from a frail to a non-frail state, so in terms of recovery. From robust directly to frail, but of all the robust transitions, 8% were from a robust to frail state. From 3.5% were from a robust to frail state, and 8% were from a frail directly back to a robust state. Okay. So just to orient you to these slides, we're now looking at what are the relationship between socioeconomic factors and chronic comorbid disease as it relates to these transitions. And just from a epi frame, again, so not crossing 1, something less than 1, excuse me, is, so we're looking at it's less likely to cause progression, and conversely, greater than 1 is more likely to cause progression. So generally, as you would expect, for every 5-year decrease in age, you're less likely to progress to frailty. Having a high school education or greater, you were less likely to progress to frailty. So that's transitioning from a robust to frail state, non-frail to frail state. Being employed also as well, right, was significantly associated with a lower likelihood of transition to frailty. not having any depressive symptoms. So we use measured the CSD to measure depression in our cohort, or depressive symptoms was significantly associated as well with the lower likelihood of frailty progression. And then just to orient you here, the reference here is having 3 or more chronic comorbid disease conditions. So having less chronic comorbid disease conditions, you were less likely to progress to frailty, right? And having none at all was best. If you adjust for all these factors, HIV is still a significant factor for progression to frailty in this model. This is pretty much just the converse of what I just showed you. So we find the same thing in terms of transitioning back, so recovering from frailty. That is from a frail to non-frail or frail to robust state. So that is younger age, higher education, status, employment, absence of depressive symptoms, and lower comorbid disease conditions were all associated with promoting frailty recovery or transitioning back from frailty. So the next thing we sought to do was to, one other thing here. So we did look at individual comorbid disease conditions that we were looking at, and this is history of in this consideration. But we found that both diabetes, high blood pressure, stroke, obesity, and kidney disease were all significant predictors of progressing, independent of each other, progressing to a frail state, and not recovering from a frail to a non-frail state as well. So we next looked at what are the relationships between, so we see the relationship with HIV overall, but what about specific HIV clinical parameters or HIV disease states? So we're looking here, thinking about viremia, thinking about immunosuppression, thinking about prior AIDS status, and so forth. So so we're looking here now at frailty progression, so transition from a robust to frail state or non-frail to frail state. And so compared to those who are viremic, attaining virologic suppression was you were 30% less likely to progress from a robust to frail state, and 26% less likely to progress from a non-frail to frail state. And importantly, this actually reduction in likelihood of frailty progression with virologic suppression actually approached what we saw with the HIV, folks who were actually HIV negative. Similarly, not having a prior AIDS diagnosis was significantly associated with reduced likelihood of frailty progression. And so CD4 nadir, which is a measure of how bad did your disease get in the past, right? Having a high CD4 nadir, namely a nadir greater than 500, was also associated with a significant likelihood, significantly reduced likelihood of frailty progression. We see the converse here. Again, compared to folks who are HIV viremic, achieving HIV virologic suppression, you are 43% more likely to transition back from a frail to robust state, and 34% more likely to transition from a frail to non-frail state. And again, not having a prior AIDS diagnosis and having a CD4 nadir greater than 500 were all associated with greater recovery from frailty as well. And so one of the questions is potentially, right, this is measurement, right? So measurement across multiple different domains. And so the question is there some noise here per se? So we actually, again, try to look at hard outcomes. And for this, looking at mortality. So what do these frailty transition states actually mean? And effectively, we do say effectively that every state above, other than staying not frail, each state progressively is associated with higher mortality. So that is folks who had frailty at one point had a higher mortality than those who are not frail. Transitioning from non-frail to frail, you are more likely to die subsequently to that transition. And appreciably staying frail, we saw the highest mortality risk of about 300% or so. In our adjusted models compared to remaining not frail as well. So that just to say that these transitions are important in and of themselves. So across these HIV cohorts, the associations that have been seen in HIV cohorts include increased age, socioeconomic challenge, including low educational attainment, low income and unemployment, depressive symptoms, increased comorbid chronic disease, and poorly controlled HIV infection or AIDS. These have all been associated across a variety of cohorts now with frailty as well. So we talked about the epidemiologic potential targets to address frailty and disparity in HIV. I just want to toggle to thinking a little bit about the biology and potentially biological targets, thinking about these pathways. Sorry. So for this, the first thing we looked at was inflammation. And so we know that inflammation is central to HIV pathophysiology, right? So through immune activation, loss of immunoregulatory cells, immunosenescence, there's been positing that loss of gut mucosal integrity occurs with HIV as well, which leads to microbial translocation and subsequently downstream, again, immune activation and systemic inflammation. And that even when you give someone effective HIV medication and you get them suppressed, that you still have persistent inflammation, right? So there's still chronic inflammation that persists, and that could underpin clinical disease in HIV and the heightened burden that we see. So to look at this specifically as it relates to frailty, we turn to this inflammatory index. And this is an index that was developed in two key geriatric cohorts. One is in Chianti, and the other is the Cardiovascular Health Studies, CHS, which is where the Fried frailty phenotype was initially developed. And so taking a series of NF-kappa B related cytokines, it was found that combination of interleukin-6 and soluble TNF receptor 1, that aggregate marker was found to best capture the inflammation effect on mortality in those cohorts. So we sought to validate this score, first of all, in this index in our population. And so this is this index as it relates to mortality here. So to orient you again, the green line here reflects the lowest tertile of inflammation. And so for every increase in tertile, you see a decrease in survival, an increase in mortality. So this is the middle tertile here. And so the lower down you are on this graph, the higher your mortality, just to orient you as well. So the highest tertile of inflammation is here in red. And so again, this inflammatory index is, and increased inflammation in our cohort is highly predictive of mortality as well. So we looked at this inflammatory index score in relationship to frailty and did find a significant association of increased inflammation in our cohort as reflected in this score with frailty. And so putting this now, nesting this within the transition models that I just showed, right? So that I mentioned, we looked at how does this inflammatory index score play out against frailty progression and recovery. So we looked at 800 participants, 2,400 person visits, and we found that for every standard deviation decrease in the inflammatory index score, there was a 22% decrease in transitions from a non-frail to frail state, and a 30% decrease in transitions from a robust to frail state. So decreased inflammation, less likely to progress to frailty. Conversely, for every standard deviation decrease in the inflammatory index score, there was a 29% increase in the likelihood of transitioning from a frail to non-frail state, and 44% likelihood of transitioning from frailty to a robust state. Again, so decreased inflammation, greater frailty recovery is what we've seen. So these are a range of correlates that have been looked at in between with frailty and HIV cohorts. So inflammation, IL-6 soluble TNF receptor 1, CRP, change in hormone levels such as testosterone, DHEAS. There was one study done using fibroblast growth factor 23, which is a measure of bone metabolism. There's a recent study that just came out by Christine Wilenson's group looking at mitochondrial haplogroups with haplogroup H being associated with frailty. And then there's been some epigenetic studies and looking at DNA methylation as well in these cohorts. So I want to just, I think this is my last group of things, is just touch on the concept of frailty and cognitive impairment. So the frailty construct that I mentioned before, I mentioned physical frailty, and there's been interest in what is the linkage, right, between cognitive impairment and frailty in general, whether it's part of the construct or but definitely is it related, and and this all stems from this concept of shared pathophysiology that exists between cognitive impairment and frailty. The points in green are areas that have been identified as potential HIV effects. So I'm just going to just briefly mention some of our studies on this line. Again, there's these bidirectional associations that have been proposed between physical frailty and cognitive impairment, and the question of whether these are the same or related domains has arisen. This is the range of cognitive assessments that we've done in ALIVE, so around executive function, information processing, attention, working memory, and motor processing as well. And so this is a Venn diagram of what we see. So this is sort of a global summary of cognitive impairment in our study. So of the folks who are cognitively impaired, 83% were not frail and 16% were frail. Of the folks who were frail, 75% were not cognitively impaired and 25% were. So there's relation, not complete overlap of these constructs in our cohort. And then the last thing we looked at in terms of this is what's the relationship with mortality again, right? So, and we find that cognitive impairment and frailty were independently predictive of mortality in our cohort, adjusting for a variety of different factors. So in summary, we find that frailty burden is heightened in HIV. In HIV, frailty pretty much predicts most of the things that have been seen in non-HIV older populations as well, including hospitalization risk, mortality, disability, quality of life. And this all seems to be independent of comorbidity and HIV disease stage. And then we find that physical frailty and cognitive impairment seem to be independent predictors of mortality in HIV. So going back to the original premise of thinking about frailty as a potential target for reducing vulnerability and disparity in HIV, what are the things we potentially could do to think about this? So definitely prevention or reducing chronic comorbid disease, that sounds easy. Modulating, thinking about socioeconomic factors and what are the pathways from these socioeconomic factors to frailty, and how can we interrupt those cycles as well. Clearly attaining virologic suppression, I mentioned that we have some ways to go. We're at 50% in terms of our population alone. And then the findings that we found with CD4 nadir and AIDS, I think, are reflective of allostatic load over time, thinking about preventing progression to advanced HIV disease stage and getting things early is key as well, and legacy effects. And then thinking about the concept of whether inflammation may be a key target and all the upstream things that come from inflammation in HIV and non-HIV alike as potential targets. So this is just one framework that we've proposed for looking at this. So definitely there are cellular molecular factors that to be considered. There's the whole range of comorbidities, potentially thinking about pro-inflammatory conditions and otherwise. And then I think importantly as well is thinking about psychosocial and environmental considerations. So mental health, nutrition, physical activity, socioeconomic stress, resilience, and substance use. And the construct is that this all flows into the construct of frailty that's been proposed more broadly in terms of response systems such as inflammation, neuroendocrine dysfunction, as well as altered energetics that feed into these various pathophysiologic pathways that ultimately seem to culminate in this vulnerability to all of these bad outcomes. So I'd like to close by thanking the Alive participants and all our Alive study staff, all the folks who helped with data collection for the study, including Mohammed, Jackie, Jason, Horfin, Vincent, and Jack, Hopkins Frailty Working Group, who've been very helpful in thinking through these considerations, all of my colleagues who've worked on this studies together with me, including the PIs of Alive, Shruti Mehta and Greg Kirk, and all of the supports that we received for this work from the Hopkins Center on Aging and Health, the Older Americans Independent Center, the Center for AIDS Research, the Robert Wood Johnson Foundation, and the NIAID, NIDA, and NIA for R01 support for this work as well. Thank you.
Thank you so much. It was an excellent talk. We have some time for questions. If we...
Thank you very much for that. The frailty phenotype is a composite, as you've shown, of 5 things. So these transitions are not transitions necessarily even across all 5 entities. I could see where treatment exhaustion might be more labile, certainly weight loss, if that could stabilize that. So could you comment on if there are specific components that were most likely to drive the flipping?
Yeah, so we are still looking at that question. I know that our frailty group in general has looked at the question of which comes first. So Karen Banding Roach, for example, has done a lot of work on thinking about what's the evolution of this. Whereas thinking of this as a critical mass construct, potentially, but I think we definitely are still looking at those considerations, yes.
Hi, good morning. Right here.
Sorry, hi, how are you?
First, I just want to commend you. That was an outstanding talk and a really beautiful progression of work. But one thing that was very noticeably absent was whether people were treated or not. And so I'm wondering if you would maybe comment on antiretroviral treatment. And I'm assuming that was an adjustment factor. I might have missed it, but hoping that you might be able to talk about how this stratifies against treated and non-treated. Thank you.
Yeah, so this is the component we're thinking about this. So in our cohort, effectively, virologic suppression is a measure of treatment. We're a community-based cohort as well. And so this is our primary readout in that regard, effectively. In our cohort overall, we've looked at trends from 1990, over the last 20 years. We appreciate for this cohort that we're getting better. So what I mean by that is the transitions from suppression to rebound are getting smaller. Even so, one of the challenges for folks with injection drug use has been that, as compared to the max cohorts or so forth, where their suppression rates are really high. People move in and out a lot in our space. But that in and out movement over the last 2 decades has been much better. And so we're getting closer, but we still, I guess my point here is that we still need to do better in terms of suppression. And clearly, getting on ERT and staying on ERT with the goal of getting suppression is critical from these transition points in terms of reducing frailty progression and promoting frailty recovery.
Hi, thanks a lot for the great talk. I was impressed by the high rate of frail to pre-frail in your cohort, and the lack of pre-frail to frail, only 8%, I think you showed maybe.
So 8% was the non-frail to frail.
Non-frail to frail.
Yeah, or sorry, let me get back to that.
Yeah.
Yeah, so
I was just wondering if you had looked at if you guys had looked at in this cohort the role of hospitalizations as a driver here of this high rate of frail to non-frail, and you just happen to be assessing people as they're coming out of the hospital and in this sort of recovery period after they've been ill. I mean, they're high rate. I would expect a high rate of hospitalizations in this cohort of patients.
Yeah, so we had about 500 hospitalizations. Clearly, frailty was predictive of, so preceding hospitalization in our cohort, and that was the data that I was showing here with this as well. But there have been studies that have looked at intervening hospitalizations as a key point in this pathway as well. We don't have, because we're a community-based cohort, we do not have the granular data linked into all these different hospital systems to be sure. But we have thought about that from looking at hospitalization as a stressor, right, that could potentially be used to determine whether this frailty construct in our setting actually makes sense in a sense. The thing with hospitalization, though, is that people are hospitalized, well, as we've thought about that as a consideration, people are hospitalized for a variety of different things. So someone may go in for an elective procedure, for example, versus a hip fracture versus the flu, and those may reflect different things as well. So, but I think we've definitely been thinking about that in terms of looking at that possibility.
Hi, I'm Bill Hazard.
Yes.
We met
Hi,
earlier and
yes.
have traveled the same paths a lot. I do remember the first patient I ever saw with HIV out in Seattle. I said, wow, I've never seen this before. It had not been named at that point, but there was something gaunt about the person who had been afflicted that I'll never forget, and that's before I went to Hopkins, et cetera, et cetera. But also, there was some impression that the process of aging actually was accelerated in people with HIV. And now it almost seems like they're inextricably related. Has it actually been teased out as aging per se? Because they used to study people over 50 with as models as opposed to 75 for aging and so forth. Is aging itself accelerated, or is it all the same gamish?
Yeah, that seems a very existential question. I think it's interesting. There has been a lot of discussion in the HIV world about accelerated versus accentuated aging. I think one of the strongest reflections or evaluations of that has been studies done looking at a variety of different malignancies and looking in standardized ways at the curves of these things in terms of the HIV population compared to the general population, and thinking about, is it a peak, or does it go up, or does it shift? And that study actually, which was linked into the cancer registries, actually showed different things for different cancers in terms of some cancers, it was a shift. Some cancers, there was no shift. They had the same midline point. Some were up and some were down. So I think there's that in of itself. But I think part of this speaks to the concept of what is the biological underpinnings of all of this considerations. And I think going after the biology to answer that kind of question, I think continues to be key. Yeah.
All right. Thank you, everyone.